All right, great. Again, this is Alex McDevitt with the RHSC Secretariat. Thank you everyone for joining this morning or this afternoon, depending upon where you are. Before we get started, I'm just gonna hit a couple logistics points. First is that all attendees are automatically muted. Throughout the presentation, you are welcome to write in your questions into the questions box, which will be present in your control panel. We will save all question and answers for the end of the presentation, so please be patient. We will get to your question. And with that, I will turn it over to Samia Ramarao to welcome us.
Hello, everybody. Welcome. The Nerd Caucus is pleased to host a webinar today on what we are learning about consumer preferences for an injectable contraceptive in Nigeria and Uganda. Key findings from a qualitative and quantitative research. As you know, the caucus aims to share information on new and underused products as they get introduced and go to scale. We believe this topic today is timely and of interest to the NERD membership. I'm pleased to present the presenters on the webinar today, Lenita Dorflinger from FHI 360, Mushira Elsan, and Kim Morneau from Roots to Results. So over to you, Mushira.
Thank you, Samia. So just briefly to go through the agenda with you all. Lenita will be framing this research, which is extremely helpful in order to really contextualize our work. Then I'll be running through very high level and key findings from the qualitative work that we've done in 10 minutes. Then Kim Morneau will be running us through the main quantitative findings. Lenita will come back and do some really key takeout conclusions for us to all leave with. And Samia will then moderate our discussion. And just to note, if you can please wait until the end where we have this discussion section to really verbalize any questions, whilst throughout the present webinar, putting your questions in the box, we'd really appreciate that just to make sure that we can use the time fully. And I'm just going to hand over to Lenita, who's going to actually frame this research. Thank you.
Okay, thanks. Thank you so much, Mushira. So for the next few minutes, I'll frame the research you'll hear about today from R2R, which adds to the growing knowledge base on preferences, acceptability, and factors that impact women's uptake and experiences with injectable contraceptives, and which will provide additional information relevant to the development of new contraceptive technologies more broadly. So to frame, I will start with a snapshot of current modern contraceptive use in Nigeria and Uganda, where the research was done. Then I'll provide a very quick overview of the knowledge being gained in real time from the introduction of DMPA sub-Q in several countries. And finally, I'll quickly highlight some relevant data from recent product design and acceptability research on longer-acting contraceptives that was funded also by the Gates Foundation. So next slide, please. So in Nigeria, the overall modern method CPR is relatively low. It was just 19% in 2018. And as you'll see in the lower left panel here, among married women, injectables are about a quarter of the modern method mix. And this proportion has declined slightly as implants have been introduced. The lower right panel shows similar data for unmarried sexually active users, where injectables play a much smaller role and male condoms are a predominant method. Next slide, please. In Uganda, the modern method CPR is almost double that seen in Nigeria. It was 36.3 in the most recent 2018 survey. Among married women, as shown in the left panel, there's been a rapidly changing method mix with introduction of implants, which were over a quarter of modern method use in the latest survey. However, injectables, the IM and sub-Q combined, contribute almost half of modern method use. Uganda was an early introduction country for DMPA sub-Q, and in 2018, you'll see about 20% of injectable users actually reported using the subcutaneous product. The Uganda survey also provides an analysis specific to younger women, which I think is relevant to today's presentation, women ages 15 to 24, and you'll see that on the right panel. Among married women in this age group, injectables and implants also dominate the mix even more than they did for married women as a whole. But among unmarried sexually active women in this age group, condoms play a much bigger role, and that of implants much less. Next slide, please. So as you've seen, the use of DMPA sub-Q has expanded relatively quickly where it has been introduced, and donors, including the Gates Foundation, USAID, and CIF, have supported acceptability and introduction research, including on self-injection. And this slide is just a quick snapshot of key findings over the past few years from research in several countries, conducted largely by FHI 360 PATH and our local collaborators. Referring to the general preferences on the upper left, given when current Depo-IM users in Senegal and Uganda were given an opportunity to try DMPA sub-Q, 80% or more preferred the sub-Q product after 3 months of use. Their stated reasons included fewer side effects or perception of fewer side effects, faster administration, less pain, confidence in effectiveness, and just general statements like they liked the method. Providers said they preferred the prepackaged presentation over a vial and syringe and felt it was easier and faster and thought that it had the potential to increase access, as well as the possibility that their clients would prefer it. So DMPA sub-Q is registered in a number of countries for self-injection. The self-injection feature of DMPA sub-Q in the Uniject presentation makes the product attractive to many users, providers, programs, and donors. And in studies to date, the majority, albeit not all women, prefer the self-injection over various provider options where it's been studied, whether that be clinic-based or community health workers. A randomized control trial in Malawi, done by Burke and her colleagues, compared provider-administered injection to self-injection over a 12-month period. And they found that continuation was significantly higher among the self-injectors compared to injection by either CHWs or clinic-based providers. And the reasons that users said they preferred self-injection included that it was easy to do, it saved them money and time, they didn't have to worry about stockouts, and they had the perception of fewer side effects and less pain. And the provider preferences were similar to what I said earlier. They felt self-injection options would save them time, and they had the perception that it would be good for women. All studies have shown the importance of training for women to feel confident with self-injection, to use the proper technique, know how to store and dispose of the devices properly, and know how to manage their re-injection timing. But overall, self-injection research has documented that there's an important role that DMPA sub-Q can play in expanding method mix and particularly expanding self-care options for women. Next slide, please. So some of the new data you'll hear today is specifically related to the potential of a 6-month injectable or self-injectable. And relevant to this, the Gates Foundation recently supported the study in Uganda and Burkina Faso by my colleagues at FHI 360 to explore potential preferences of a variety of longer-acting products that are in development, and they're seen in the lower part of this slide. The study included both quantitative and qualitative phases, with the quantitative phase being implemented through a module in the PMA 2020 surveys. So the next slide, please. Just at a high-level summary, over 3/4 of women said they would try a new method if it was offered. To me, this is a large proportion, suggesting that for many women, the current options really aren't ideal, and I think many of us know that. Important product characteristics that women consider when choosing methods are listed here, including high effectiveness, the rapid and predictable return to fertility, few side effects, especially bleeding changes, which we've heard about for decades. We know there are important differences in what patterns of bleeding are more or less acceptable. The ability to use postpartum, and then of course access and affordability. In this study, more women were interested in injectables than any other new long-acting form, and that might somewhat relate to just familiarity. For longer-acting injectables, their perceived benefits were from both the demand and the supply side. So I think with this framing, I'm going to turn things over to the Roots to Results team to present their new research, which is relevant to potential interest use and the positioning of various injectable contraceptives within the method mix. Thank you. Mishira?
Thank you, Lenita, for such an incredible synopsis of all the work that's been done so far, and obviously work that we are building on. So if we can go to the next slide. Thank you, Alex. Cheers. So just a quick introduction to the research, just so you all know, I have 10 minutes, so this is going to be a kind of roller coaster ride with me. Just to introduce the research, we did one qualitative phase, and the main aim of that was to really understand from users and potential users the critical elements of their contraceptive journey. So we did a HCT piece, and then also to understand their reactions to 3 profiles. One was for Depo-IM, the other was for DMPA-SC 3-month and 6-month. At a total sample of 600, And we walked them through various focus group situations and exercises and gave some really interesting information. This qualitative phase was then fed into our quantitative phase, which had two major aims. The first was to test the 3 fully developed concepts, which we refined from the qual phase. And the third element was to actually quantify what we could see as a market uptake for all 3 profiles. And for the rest of this webinar, I'll be presenting the key findings from the qual phase, and Kim will be presenting the key findings from the quant phase. Next slide, please, Alex. Thanks. And again, thank you, Danny. Okay, so the qualitative sample, just to explain how we got this 600, we discussed quite in depth with the Gates Foundation the kinds of people that we really wanted to talk to during our qualitative interviews. And we actually splitted these into 8 different types of focus groups. So as you can see, they're listed below. We had 18 to 20-year-olds who were discontinued Depo-IM users and mothers, and vice versa, those who weren't mothers. Then we had married mothers who also discontinued Depo and IM. And this was mainly because we wanted to understand their journey with Depo use. How far did they experience the side effects, for example, which is all too often blamed for the discontinuation of the Depo-IM. And we then wanted to see those people who haven't actually used any modern contraceptive. So we had a naive modern contraceptive user group, and these were never users of any contraceptive that is considered modern. We had another group which was satisfied Depo-IM users, and we had a group of satisfied DMPA-SC users to see are those users who are satisfied, are they the ones who aren't experiencing such heavy side effects, for example? And we did find that was the case. And then we finally had 2 other groups, which are actually male partners of those who have discontinued use and continued use, just to see again what their role was within the journey for the contraceptive and how they felt about these new profiles and new opportunities with the injectables. Next slide, please. This is going to be very brief. As I explained earlier, with the 8 different groups, we created 5 different journey maps. And you can see 3 are on the page here. What we had the individuals do within the group was actually fill out these maps alongside 2 other members who were the moderator and the note taker who supported the group. There were around 6 women in each focus group, so there was enough support for everyone and everything was translated. And they went throughout these charts and actually described their journeys. Some of them obviously continued, others had stopping points like the exclamation mark where we asked them to express why they discontinued use. Next slide, please. Each of these maps were actually then translated into a whole synthesis period. This was done via each map being analyzed individually and then as a group within their focus group type, so naive users, for example, really trying to understand thematically what was happening throughout that journey, who were the major players, who were the kind of people that really encouraged use, and who were those people or experiences that disencouraged use. And then the maps were done on an overall thematic level across the board. And as you can see, the post-it notes are a fashionable addition to HCD work or human-centered design work. And we then synthesized to create a bigger journey map expressing what our users as well as male partners actually experience when it comes to their contraceptive journey. So if you go to the next slide, you'll just get a very brief outline. I won't be able to run us through this, but it'll be available online. And here you'll see this is the journey map that we created alongside Matchboxology, really just expressing the 3 major stages that women and partners were talking about when they experienced their journey and highlighting the major kind of barriers and enablers throughout their journey. Next slide, please. Thank you. And again, thank you. We wanted to understand whether there really was a heavy negative perception of injections and if that translated into use for other injectable forms. And we generally actually found that there wasn't the negative perception of injections overall doesn't translate in a barrier to using injectable. The appeal to use is actually generally much stronger than the barrier or the block as we describe them. But it still has to be pointed out that those people who've never had an injection or never used the Depo-IM do have an initial fear to the pain. And on top of that, the side effects are a major barrier, and including those who haven't even used the IM Depo due to a lot of information being translated between friends or other users about the Depo-IM. Next slide, please. Thank you. We also wanted to do a quick summary. A lot of our work was looking at Depo, but again, we were introducing DMPA-SC 3-month and 6-month profiles. We wanted to just do a quick summary. And as we found, there were 3 major differentiating benefits, which did provide a driver to a lot of women to actually consider using the DMPA-SC. Obviously, the subcutaneous injection was one of the major driving forces in interest. As you can see that this image above on the left, this is actually something that we showed the respondents and was translated to show them actually what we meant by an intramuscular injection like the Depo-IM and a subcutaneous, to really make sure they understood what it meant in terms of having a smaller needle and what that meant in terms of things like pain, for example. So there was definitely a strong preference for the injection under the skin. The option to self-inject was also quite important to a lot of women. They did really like the idea of the HCP who was trained, as Lenita expressed before, having a trained HCP was very important, doing it for them. And there was a cohort who saw the benefit of self-injection. Again, those women were also the group of women who really did feel like they would be able to learn quite quickly from a healthcare provider and be trained by them in order how to use it themselves. But quite a few actually were still quite comfortable having the healthcare provider to do this. This may be because in some of the images that we shared, the self-inject was shown doing into the arm or into the thigh. And granted, you know, a lot of women would prefer if something was to go into their arm for someone else to do it, probably, as it seems a bit easier. The concept of the 3 or the 6 month, that was also very interesting and was slightly divided between the groups. What we did notice was that obviously a lot of women would prefer to use a 3-month self-inject over a 3-month Depo. The 6 month, there was a preference for that greater duration, generally because of the coverage. And also, as already expressed by Lenita, the kind of reduction in HCP visits was seen as an important aspect to a 6-month injectable. Next slide, please. Thank you. We wanted to do some quick fire trade-offs. The Gates Foundation have a lot of information about sort of certain tweaks or differences between the DMPA-SC 3-month and 6-month, as well as the Depo. So we decided to create a quick trade-off exercise where we went through all these differences, and each option was given to the group, and the group had to immediately put their hand up to whether they wanted option A or option B, for example, or C, and then that was noted down. So we have a good sample of 600 women answering these questions. Next slide, please. What we found here, and just this is a very summary piece for this, is that there was definitely a preference for subcutaneous. So if we look in round 1, we tested the delivery method of an IM versus an SC, so subcutaneous. And what we see is 70% of the women put their hands up for a subcutaneous, which is the DMPA. When we asked versus a provider inject or a self-inject, it's fairly split, but 56% chose the provider inject. This is probably due to that cohort that we expressed, didn't feel too confident about being able to be trained to do it themselves, but most of them did. In round 2, we tested the 6-month duration of the DMPA and provider inject versus self-inject. And provider inject was selected by 60% of the women. In round 3, we can see that we tested the 6-month duration of the DMPA provider inject syringe plus vial versus a self-inject. So in this point, it was still DMPA. However, the provider was using a vial and injection for this example. And we see a split again, and just a very small preference towards provider inject, but we see that reduced compared to the previous round. In round 4, we started introducing side effects, and we were testing the 3 months duration of the DMPA and against the 6-month duration, and the side effects that were expressed were around bleeding side effects, so regular bleeding, especially for the first 6 to 12 months, as well as spotting and sometimes not having bleeding at all, as well as weight gain impact. So what we found here was that with the provider inject for 3 months, which meant less pain, 58% would select it over self-inject 6 months, which meant slightly more pain. In round 5, we were testing bleeding side effects versus Depo-IM, DMPA-SC 3 months or 6 months. They were given 3 choices with the expression around side effects that we've just discussed. And what we found was the self-inject 3 months was at 41%. This was interesting because we see a move away from the provider at this stage, whereas before we've been seeing a preference for provider injection, and now we're seeing a move towards a self-inject. And this may be because we're discussing side effects. The last round was around the weight gain side effect. And again, we see another shift moving away from the provider 3 months into a self-inject 3 month option. So we can see that the trade-offs are causing some changes and some recalculations amongst consumers as soon as we start introducing side effects. Next slide, please. Thank you. Another human-centered design game that we created was to understand side effects. And this was an objective that was really desired by the Gates Foundation, just to really learn more about side effects, to build on the kind of wealth of information knowledge that we already have around side effects, in particular the bleeding side effects. What we did was to create a selection of side effects as well as general illnesses, and we asked the consumers and women to actually rank them in order of those which are the least likely to tolerate, so the hardest side effects to deal with, right down to the most manageable side effects. And you see the image there of women doing that themselves. Next slide, please. These were the cards that we produced. So there were 16 side effects and some general illnesses cards. Now, to explain around the general illnesses cards, we really wanted to introduce that just to add an anchor for the women and partners with illnesses that they've probably experienced themselves, and also just to really understand how to get a sense of how difficult these side effects really are to manage against the absolute of things that people are used to. So you'll see cold and flus, stomach cramps and diarrhea were the general illnesses cards that we created. So if you can go to the next slide, please. Thank you. We see here, and this again is fundamentally supporting all the other information that we already have with side effects, that the bleeding cards were topping the order across all focus group types with regards to the least likely to tolerate. So as you can see, that kind of redness all across the slide. Obviously, all our bleeding cards were done red in order to see, and you can really see that on this slide, that the bleeding side effects will consider them least able to manage alongside following on diarrhea. And then if you go to the next slide, we're going to be seeing the most manageable and acceptable, and we can see here the most manageable acceptable were cold and flu, which were our general illness. And then there was a less consistency amongst the most manageable cards in terms of which ones were considered consistently the easiest to manage. Next slide, please. I'm going to hand over now to Kim Morneau, who led our quantitative research. I'm sorry, Kim, if I ate into your time. I tried.
No, that's okay. Thank you so much. Okay, next slide, please. So what we're looking at here is a sample of nearly 700 women in Nigeria, as well as slightly more than 700 in Uganda. We looked to split this across all of the different age groups, with a particular focus to make sure we had a readable sample of those under 25 as well as those over 25. We also looked to make sure we were controlling to have a readable sample of women who were contraceptive naive versus current users or prior users. The sampling methodology was incredibly randomized within 4 different regions within each of the countries, managing for both an equal sample of urban and rural participants. Next slide, please. As we look at what the current behaviors are, we find that 2 in 3 women across both markets have not discussed family planning or contraceptives with a healthcare professional in the last 3 years. However, despite this, the vast majority of women actually said that they found it quite easy, a 6 or a 7 on a 7-point scale, of getting modern contraceptives if they wanted so. Next slide, please. I think the thing to take away on this slide is we look at what they say they have used in the last 30 days and how long they've been using that method is not necessarily the exact number of months. This isn't a chart poll study in any sort of way, but really to look at the perceived differences of the women in Nigeria versus those in Uganda, because what you find is the use of the injection was far more developed among the women in Uganda, and as we carry on through the rest of the presentation, you'll find that their responses are usually quite different than those in Nigeria, and I think a lot of this has to do with just the greater development of using this particular form and the time period in which they have been using it. Next slide, please. The one thing that you see right now is that when you ask women about their satisfaction with their current method, there's actually a high level of satisfaction being communicated across all women, despite what product they're using for contraception. Next slide, please. The thing, though, that you do find that I think is important to take away here is that when you look at the percent that are getting it for free versus, a cost, you find that, there's pretty high variability in terms of what's being provided or accessible to them for free. And then when you look at among the people who are having to pay cash for these products, what they find affordable, again, you see that there's a very low percentage, particularly in Nigeria, less than 50%, who are saying whatever the current form is that they're using is affordable to them. And again, I wouldn't take the exact costs that they're claiming they pay, as gospel here. I think it's just to give you an idea of the relative perceived expense of this across the board. Next slide, please. So what you see in combination here then is, the combination of their satisfaction with the product paired with what the actual cost is to the respondent in terms of the affordability. You can see that there's a variety of responses, somewhere anywhere from about 30% to up to 50%, who would be willing to change their method of contraception in the next 12 months. Next slide, please. Okay, so as we introduced this, we introduced 3 fixed concepts to start. The Depo DMPA-SC 3 months, and then also 6 months. And we showed them in that sequential order. When you look at the interest in using here, one of the main reasons why you see Uganda being much higher in terms of interest in using for the current injection users versus the non-injection users, particularly for the Depo is because we also gave them the option of saying, this is what I'm currently using. So this represents here the percent that were top 2 box on a 5-point scale for intent to use if it was made available to them and recommended to them by a healthcare worker. You can see that across the board, the current injection users tended to be a bit more excited about the product or willing to use a new product, whether it's the thing they're using today or one of the subcutaneous injection formulations. However, I think it's also important to take away that among non-injection users, there's still a high interest in using this product. We've also looked at like a switching summary here, which just looks at, based on the product that they're claiming to use today, the form that they're using today, what would be their likelihood of switching across the different products? And I think the thing to take away is among people who have not had any experience with any of the forms of the injection yet, so those that are using male condoms or implants, etc., they find it hard to draw differentiation across the different options. So, I think that they're still digesting the overall form of the contraception and the injection in general, and not necessarily picking up on the small nuances, because what you see is a high level of consistency in the switching rates across all 3 products. What we did find is that there's certain characteristics of women who tended to be much more interested in the injection. And so across the board, both countries, we found that the women living in rural areas were more interested than those in urban areas, as well as when we looked at the age differentials. There's a relationship in that as age increases, the interest in using the injection decreases. And so the highest interest was really among those who were 18 to 24. Looking specifically at Nigeria, some of the other characteristics of the women who showed an above average interest in using the product is those who had used an injection for contraception in the last 30 days, those who were in socioeconomic class 2, unemployed but seeking work. For Uganda, it was certainly more developed among people who had experience with the injection in the past 30 days. As we moved into looking at those who are interested in both the Depo and the subcutaneous, we also found that those that are not married, either single or living together but not married, are more interested in it. In Nigeria, women who had not used anything in the past 30 days had a higher propensity to be interested in using the injection. And in Uganda, it was people who had used male condoms or breastfeeding for contraception in the past 30 days. Next slide, please. Okay. This is just a summary of the switching by the different contraception options, which is consistent with what we already talked about. So let's just move on. Okay, in here, what we were looking at is why did they find it appealing or not appealing? And so for women who told us that they were interested in using it, what was really the main driver? And the main thing that we saw across the board for the IM is just the effectiveness in preventing pregnancy. For those who said they were neutral or negative towards using the IM, the biggest reasons was actually the side effects that Mashir has already mentioned of irregular menstruation, weight gain, particular side effects just in general, but really the main driver was the irregular menstruation. Next slide, please. What we looked at is for women who would be willing to consider using this if it was made available to them, what would potentially cause them to discontinue use? And the main thing, again, consistent with the qualitative research that we had done, is anybody who was experiencing heavy bleeding, that was the #1 reason that they would potentially discontinue. If they had above normal menstruation pain, also very consistent and irregular periods. I think the thing to note here is when you look at Nigeria versus Uganda, just the relative relationship of the different discontinuation rates, those in Nigeria, again, having had less experience with the product form and using an injection, tended to have a higher rate or intended rate of discontinuation if these side effects occurred than those who were in Uganda that had more experience with the different products and had a better idea of how frequently these things occurred. Next slide, please. Again, looking at the switching rate for the subcutaneous 3-month injection, I think the thing that we find is that across the board, there's much more interest in switching when you look at the women in Uganda versus those who were in Nigeria, and particularly women who are currently using an injection had a high interest in switching to the subcutaneous. Those who are using other modern contraceptives, such as the pill, emergency pill, ring, and then women who are using male condoms right now. Next slide, please. Again, when we looked at the reasons for the appeal or not being appeal, not having interest in using, they're very consistent with what we saw with the Depo IM. Main driver is the effectiveness of preventing pregnancy. However, in the Uganda specifically, you see that women are starting to draw more comments out. These are all spontaneous comments that are written in related to the benefits of a subcutaneous form. And so you see the self-administration, potential for self-administration, the size of the needle or a shorter needle. You just have a higher rate of convenience and differentiation versus the Depo in terms of the comments coming forward. And I think that's just because they're more experienced with this particular form. When we look at those that are, not interested in using, it's very consistent with what we saw for the Depo. Similarly, when we move to the 6-month injection, again, you see the exact same trend that we saw for the 3-month injection. It's higher rate of willing to switch, Uganda versus Nigeria, and women who are using other modern methods, injections, or male condoms being the highest rate of intended switching. Next slide, please. Again, the reasons are very similar. The one thing that comes across here that's different from what we looked at in the 3-month is, if you look at the Uganda slide, reasons driving the appeal of the 6-month is that the duration is coming through 34% of the time as a main reason for wanting to use this. The reasons for not using it, again, very similar. When we look at the discontinuation rate, next slide, please. The anticipated discontinuation, though, what you do see is exactly the same things at almost the exact same rate that we saw for the Depo, as being, if these things occurred, they would be likely to discontinue. Top 2 box would discontinue on this. And so again, you can see that even the convenience of the product, the duration, the shorter needle, benefits that they appreciated about moving to a subcutaneous injection did not outweigh the bleeding component or side effect that they wouldn't be willing to tolerate. Next slide, please. Okay, I think that this is really this last section here is the piece that really helps to understand what features are appreciated or not appreciated. This is a conjoint exercise. For every single respondent, we showed them a total of 8 different cards. Each card had 2 hypothetical products put together on it. All of them are injections. And each of them varied on the different 8 attributes that we have here. And we spent a lot of time the team working with the Gates Foundation to decide what these variables should be, and looking at across the type of injection, frequency in which it's being injected, the person administering the injection, time of fertility returning, level of pain from it, skin reactions at the injection site, location of the injection, as well as how accessible it would be or where you could access it. These were all variables. So every single simulated product had one of these 3 options for each of these 8 variables. And what we asked women to do is, between the 2 products on each card, they had to choose the one that was most preferred to them. Next slide, please. So what that results in is ultimately about 55, almost 5,600 choices being made in Nigeria, and almost 5,700 choices being made in Uganda for their preferred product. So then we looked at using those choices and the different combinations. We derived what was driving the appeal of the product. So, when the person, for example, in Nigeria, the person administering the injection, that particular attribute, depending on which level of that attribute we chose, that was the highest driver for determining which of the 2 simulated hypothetical products they would pick. In contrast, when we looked at Uganda, the highest driver was the level of pain from the injection. So that's not to say that the other attributes aren't important. What you'll see is in Nigeria, for example, the location of the injection, the frequency, and the access to it are all also very important. And similarly, when you look at Uganda, it's location, frequency, access, and level of pain that's driving the choice that they're making the most. How this is helpful is it helps you to see the relative relationship of things like the skin reaction at the injection site, the time of fertility returning after discontinuation, and the type of injection being far less important in terms of what's driving their selection or choice between multiple products, relative to those other 4 attributes that we just talked about in each country that are very important. If you go to the next slide, please. Okay, so then this is looking specifically at the impact of varying features for the IM injection. And so you have a base case, which is what we anchored it at. This is consistent with what we showed, or closest to what we showed in the original concept at the beginning of the study. And then we showed what could the upside or downside be in terms of % of women who are interested in using the product if you varied the attributes. So for example, if you can get the injection administered by a community health worker versus having to see an HCP, it increased the % of women who would be interested in using the product by 5.8%. If they could access it at a pharmacy versus a healthcare center, it would increase it by 7.1%. And so you can see again, like the whole point is to show the relative impact of varying some of these characteristics to increase the appeal. So this was specific for IMs in Nigeria. Next slide, please. if we look at Uganda, you can see here that it's a different, a slightly different picture versus what we were just talking about for Nigeria, in that the level of pain being present is a huge driver in how much they are willing to tolerate the product, and how much it changes the share. In contrast, you look at something like where are they accessing it? If they can get it at a pharmacy versus a healthcare center, it's still important to them, but not to the same degree that we saw in the pain attribute or the frequency of the injection. If you go to the next one, please. Okay, so now this is looking at the subcutaneous. And I think that this is really important in terms of some of the trends that Mushir mentioned in the qualitative, particularly around the person administering it. So you can see that, making it more convenient to have the injection through a community healthcare worker increases the percent of women who would be interested in using the product. And actually, in this particular case, they're more interested in getting it through a community health worker versus a self-injection. And I think that this ties a lot to the trend that we saw throughout all the data, which is just the women in Nigeria tended to be less familiar with the form, less confident about the form. They still wanted there to be some sort of health worker involvement in the administration of this. In terms of the location of the injection, this is, can you go back one slide? I'm sorry. Alex, can you go back, please? Thank you. Okay. So all right, we'll just do it from here. When we look at the injection location, across both markets, what you see is that the upper arm and the abdomen tended to be less appealing than in the upper thigh. I think that this has to do with the fact that in the simulated cards, at least 1/3 of the cards when we were on the sub-Q option always was showing it with a self-injection. And so there was a high correlation between preferring the upper thigh when it was shown in conjunction with a self-injection versus when it was being shown by other people. So, some of the other bodies of work that suggest upper arm, I don't think that, that isn't appealing to women. In this particular exercise, the way that it's set up and you're showing 1/3 of the options where it's a self-inject, they tended to be more confident or interested in doing that when it was upper thigh versus upper arm. And I think that just speaks to the simplicity of being able to do it yourself. What you can see then is on this particular one, again, some of the other attributes become more noise than anything else. It's really about the location of where they can obtain the injection, the person who's going to administer it, how frequently they need to do it, and then also where they're actually giving themselves the injection that are the main drivers. The other pieces of this, the other attributes that you could potentially vary, paled in comparison for driving interest relative to these other ones. Next slide, please. A similar trend that you see here with some of the data for Uganda as well, in that you see in this particular case, and I do find this to be one of the things that's surprising, because the women in Uganda tended to be more comfortable with the idea of a self-injection. But in this particular case, when we did it as a derived activity and not a stated responses, you can actually see that the self-injection had a negative draw on the appeal of using the sub-Q product. Very consistent with what we saw in Nigeria. They also tended to prefer upper thigh. And again, I think that that's to some degree driven by the design of, 1/3 of the cards being a self-injection product. You will see that the every 6 months was incredibly appealing. It is the largest driver for interest in using the sub-Q option in Uganda. Okay, with that, I think I'm turning it back over to Lynetta to close or to summarize.
Okay, thanks so much, Kim. I think it's hard to briefly summarize and do justice to the breadth of data that we've just heard about. I think the data do complement and reinforce and then expand on the earlier findings, more nuance related to user desires and what might be potential drivers of injectable use. The data also document the fit of injectables into the broader method mix and show that it will vary by country and by setting, as well as by life stage. Women view high effectiveness as a key positive attribute of injectables, and this continues to be consistent across research. Unfortunately, but understandably, side effects remain a very important issue. Concerns about bleeding, of course, being the major barrier to use, and bleeding changes will significantly impact continuation, as seen with some other methods. Although, as we've heard, there is a nuance to the type of bleeding pattern and the specific impact of a different types of bleeding pattern on continuation or even desire to try. Self-injection is an appealing option for many women, but training will be critical for confidence and competence. And finally, many women would be interested in a longer acting method, particularly given the convenience a product could provide. Many women will prefer the current duration, which allows greater ability to discontinue more quickly if desired for side effects. So in conclusion, I think we're watching in real time the evolving role that a subcutaneous injectable can play in programs, particularly as self-administration expands and puts the control of a highly effective method in the hands of women for the first time. So understanding and addressing the issues that are of most concern to women using injectables will strengthen not only the current programs, but also the decisions about the direction of future technology development. So thank you, and with that, I'll turn it over to Soumya.
Thank you, everybody, Roots to Results, and Lanita for this excellent webinar on learning about women's preferences for the injectable contraceptive. And I will be looking for questions to appear on the chat box so that I can post them to the presenters. I'm not seeing many questions emerging. And so let me lead with a question for the presenters. Based on the results that you have just shared, can you draw out for us some of the implications when we get to product introduction or wider rollout of Sayana Press in terms of where should the emphasis be? On one hand, we heard about women's concerns about bleeding, and clearly, therefore, there's a need for counseling on bleeding, as well as on managing the pain at the injection site or the fear of pain. How do you balance that with the convenience and autonomy that self-use will provide, as well as the differential points of care that women can access? How do we, as a program with limited resources, where should the emphasis be on these different aspects?
I think, Soumya, your question is extremely important. Introduction in terms of the work that we have done is a completely different sort of art form. But in terms of our research, I think what makes it very clear is that obviously encouraging women with two options, whether that be one where they are self-sufficient and can actually go and be trained and do it themselves, that demands access to healthcare providers and access to trained healthcare providers, and also the kind of space and ability to discuss these things with a healthcare provider, as well as not just being left to conduct and inject yourself, but the ability to go back should there be side effects, to talk to a healthcare provider about them. So education and access seem to be playing on both fronts, whether you're going to a provider for them to inject or whether you're doing it yourself. And I think from our research and from other research that we've conducted, those two aspects are probably some of the most important things to consider, whether you're actually giving people access to the injectable as well as actually just information and support and advice, because a lot of the time the women aren't actually fully understanding the side effects and that they are either normal or okay or nothing's wrong with you. And understandably, through our research, I don't think we have the answers for that. We just know that access and education will prove to be extremely important, as well as advice and access to advice on using these products.
And to just add on what Mashira is saying, I think it's a stepwise progression in terms of how you roll out the convenience. So the thing that you see in Uganda, where there was more familiarity with the form and how it would work and how to use it, and that it's somewhat simple, they tended to be more apt to, at least on a stated basis, spark to the idea of self-injection, versus I think when you look at Nigeria, what you see is that it needs to be a gradual build, that, you know, the convenience story in the beginning really needs to be about the fact that you could get this from a healthcare worker or at a pharmacy without actually needing to go to a physician's office for this particular form. That was the level of convenience that seemed to spark to them, and that they were willing to, you know, that they found you know, as an added value, but not having a negative draw in terms of having to do it themselves. I think it's a gradual build to the benefit of do it yourself as being one of the key drivers, and they have to get more familiar and comfortable with the form before they're willing to accept that as you know, the main benefit in the convenience story.
Thank you. There's another question which came about, and this relates to if there were any differences by age. Did you see any differences in preference between young adolescents versus older women?
Yeah, there's actually a direct inverse correlation between age and interest in the injection. And so as the age groups skewed younger, the interest in using an injection skewed higher, and they actually, you know, were inversely related to each other. So that when you got to the women that were over 40, for example, they, you know, they had a very low interest in using the injection.
Thank you. So now I want to take a slightly different question that came about, which is kind of methodological in terms of, given the prominence of side effects emerging as an important factor about which method women would like to use, how much of it was derived from the way the cards were developed for the side effects? How did you decide which side effects to display on the cards that were shown in the qualitative phase?
So we showed any side effect that was related to either Depo-IM or DMPA-SC, and then added in 3 general illnesses cards. So any side effect that is typically described for and the injectable was utilized and designed a card for. So in total there were 16. 13 of them are actual side effects that anyone should be counseled on if they were to consider using the Depo or DMPA-SC.
So were you able to winnow out some of those side effects? Because presumably you picked up all the side effects that are commonly listed in our handbooks, but they're not all rising to the same level, right?
Yes, so I mean, the bleeding side effects were all pretty much uniformly selected as the most difficult to manage. Other questions that we asked around the side effects were around those actually experienced. So overall, there were more side effects reported by the Nigerian sample than the Ugandan sample. In terms of personally ever experiencing them. Again, we have to remember that, you know, part of our sample were Depo-IM discontinuous, a largest portion of our sample, of which there were 3 different focus groups, were discontinuous, so wouldn't naturally be experiencing potentially those side effects that we're talking about. But in terms of countries, the Nigerian samples expressed that they experienced more side effects, which was interesting. Side effects that were experienced and perceived as worst were normally the bleeding side effects, and the side effects that were experienced and stated as manageable tended to be change in sex drive, which was mentioned in Uganda, headache, weight gain, dizziness, and stomach cramps for both countries. But overall, where the inconsistencies come about are actually the side effects that were considered most manageable. Here's where we see slight differences between groups, between countries. But in terms of this research, what was interesting, which was most relevant for us, is what side effects were considered least manageable, and in which case they became a lot more consistent across the different countries. And obviously in terms of groups, in terms of naive users, there's very little experience with such side effects because none of them had been using modern methods.
Thank you. And I am not seeing any other questions that's coming up.
Sonia, I see several questions that on my side. It's hard for me to read them, but I'm seeing 3 or 4 additional ones.
So if you can see them, would you like to address them, Lanita?
Or not address
We have 3 more minutes, so make your pick.
Let's see. My box is really small, and so it's hard to see. There's one that says, "I'm surprised by your findings for preference self-injection." Let me just see if I can find it.
I've got it.
Yeah, Lynetta, I actually read that question as well. And so I think that the difference, if it's the one in comparison to other research that had been done with people who were using, who are users of the injection right now. And again, I think this is a point that we've consistently been trying to make throughout this presentation, is that as the person becomes more familiar with the form, and has more experience with it, they tended to be more discerning on some of the other characteristics, such as the subcutaneous form of it, the size of the needle, the ability to self-inject. But these were all among the people, you saw that those things came through much more consistently in the Uganda data, where you had a higher base of people who, even if they weren't a current user, had experience with the form in general. Versus in Nigeria, this was my point in the earlier comments, is just that at that point in time, they don't appreciate from a paper concept or an advertisement, however it would present this information initially, until they have some experience with the form, they don't appreciate some of the upgrades of a subcutaneous relative to an intermuscular. I think that they're just trying to get their head around the basics of the form in general, and aren't necessarily appreciating that. So if you have users in one study, I'm not surprised at all that they would be more appreciative of the self-injection versus our study, which had a base of, on purpose, a base of naive contraceptive users overall, as well as a large base of people who had never used an injection before.
And I think I would just base that as well from the qualitative perspective. A lot of the women, you can see that sub-Q is obviously a nice improvement, but it's not an entire leap away from the Depo, especially when you look at side effects. So when you see the trade-off slide that we presented, what was very interesting actually being in all the groups was seeing how the interest for sub-Q was so high as the form itself. But as soon as you reintroduce the side effects, which are still very similar, in fact, the same as Depo, the interest actually does dwindle a little bit, because it's no longer a big leap that they were expecting, because you've only adapted or updated the actual needle size and less pain, of which the pain of an injection is understandably not considered a major barrier. So I think that again has to be sort of considered when looking at our results.
So we are this is Soumya Ramarao, Chair of the NERD Caucus. So we are at the top of the hour. So thank you all to the presenters. And over to you, Alex, for any last remarks before we close this webinar.
Great. Thank you so much, everybody, for this super informative presentation. We will be sharing a recording of the presentation along with the PowerPoint slides that have all of the data noted in them. And we will also take in the rest of the questions that have been contributed to the questions box. There are quite a few that we haven't been able to get to, so we will address those in writing and send the answers through the listserv, the NERD Caucus listserv, along with the recording and the slides. Please feel free to reach out to me with any other questions and comments. And again, thank you so much to our presenters. This has been great, and we look forward to continuing this discussion.
Thank you so much, everyone.
Thank Thank you. Bye-bye.
Thank you all.